So let's start a very important topic. First, I have represent basically a case to you to understand basically what we're gonna start. So let's start it. Bismillahirrahmanirrahim. In this patient of 55-year-old man present with a 6-month history of worsening epigastric pain described as a burning sensation. Okay, so here is burning sensation. He noticed the pain worsen when he is hungry. He feels nausea with the pain but not vomit. There is no change in the bowel habits and his weight is actually more or less stable. He smokes 10 cigarettes a day and drinks socially. He has been to see his GP who has suggested a ranitidine to the ranitidine, but he has not helped it. On examination, he is standard in his epigastric, but examination is otherwise unremarkable. So, in this number, first is the worsening of epigastric pain. The patient comes with a 6 months history of worsening epigastric pain, which is due to the burning sensation. And basically, the pain actually, he notices that the pain is worsened when he is actually hungry. Okay, the patient feels nausea, but there is no vomit actually, and there is no change in the bowel habits. His weight is actually normal, more or less stable. He smokes actually 10 cigarettes in a day and drinks also. Okay, now it is basically a classical actually scenario for the peptic ulcer. Okay, now we'll study actually this is a scenario for the peptic ulcer. Moving towards peptic ulcer, we will discuss the definition, comparison of the duodenal and gastric ulcers, their etiology, and then clinical presentation, how you will manage, and the emergency scenario. So basically, you can see here the this is basically like erode. Peptic ulcer basically also occur when the mucosal lining is actually damaged. So basically the acid is releasing and it is eroding your stomach lining. A break in a superficial epithelial cells penetrating into the muscularis mucosa. It is actually when your epithelial layer becomes discontinuous. Now moving towards this. This is the peptic ulcers of stomach and of duodenal. You can see here. Okay. Duodenal ulcer. Now moving towards comparison. If you compare duodenal ulcers to the gastric ulcers, so the incidence is more common of the duodenal ulcers as compared to gastric. The anatomy is like first part of duodenum interior wall and the lesser curvature of the stomach. The gastric or peptic ulcer occur in the stomach. Duration. The duodenal ulcer can be acute and chronic, but the gastric is only chronic. The malignancy is more common in the benign and malignant is gastric ulcer. Okay, what are the risk factors what you asked about in the history means what things you should ask in the history from the patient. Number first, like about you will ask about H pylori, number 1. Okay, my numbers second is very important about the non-steroidal anti-inflammatory drugs that might the patient has on like aspirin or other these NSAIDs. Okay, steroidal therapy which can also called ulcer, smoking you will ask from the history, alcohol uptake, genetic factors, and then Zollinger-Ellison syndrome, which is a very rare syndrome caused by gastric secreting tumor. Blood group O and hyperparathyroidism. In hyperparathyroidism, the peptic ulcer can also occur. Now, what is actually the H. pylori? You will have studied in your second year biology. Basically, this is actually a bacteria that causes actually peptic ulcer also. It is a urease producing bacteria, gram negative bacilli. Most of them in developing countries. Infection increases with the age. What happened that basically when your mucosa is infected with H. pylori, so there is inflammation. This inflammation is called it gastritis. This gastritis increase the gastrine secretion, and when your gastrine secretion is increased, so there is actually metaplasia of the gastric. Damage to the mucosa and ulceration. There is increased risk of developing gastric adenocarcinoma, means there can be increased chances that you can develop adenocarcinoma. Now, take a focused history. Take a proper history from the patient, okay, about this. Differential diagnosis for epigastric pain. Okay, if you go from surgical point of view, so biliary colic, acute cholecystitis can also be there. Pancreatitis, perforations of viscous and acute appendicitis and malignancy. In medical form, GOD, MI, PE and pneumonia. Okay. Now, what can be a symptoms of mostly the patient comes with the peptic ulcer disease? Asymptomatic, no such symptoms, but epigastric pain is patient has nausea, oral flatulence, bloating, and distension of intolerance of fatty food. Very important. Heartburn. Most of them says that I have a lot of heartburn. Pain radiating to the back again. So the patient can come with epigastric pain, bloating, intolerance of fatty food, heartburn, and pain radiating to the back. Alarming signs for epigastric pain when you have epigastric. So there are chances of chronic GI bleeding. Okay, the patient can, when there is actually bleeding, so you can be deficient of the iron, so can occur anemia. Progressive unintentional weight loss means there's actually unintentional weight loss. Progressive dysphagia, difficulty in swallowing, persistent vomiting, and epigastric mass can be. Patients aged with 55 and older with unexplained and persistent recent onset of dysphagia alone. So if the patient is old, so there will be an unexplained, he cannot explain, and persistent onset of dysphagia, he cannot swallow the food. So there can be alarming symptoms if you have epigastric like GI bleeding, iron deficiency, weight loss, progressive dysphagia, and persistent vomiting, and epigastric mass may present. H. pylori. How you test H. pylori is basically, now for H. pylori testing, you will see the C. urease bread test. Very important actually. Okay. Now stool antigen test. You will check in the stool for the antigens. You will do serology and endoscopy with biopsy. Okay. Other diagnostic plan like stool for fecal occult blood. There might be a hidden blood in your stools. Then you will see for the complete blood count, liver function test, amylase and lipase. Okay. Then H. pylori can also be diagnosed, which I have told you for the breath test, can also urea breath test, blood stool antigen SSA, rapid urease test on the biopsy. Upper GI, okay. So when we do actually endoscopy, so what are actually the things or what should be considered here that you will do upper GI endoscopy? Any patient when he is more than 50 and has a new onset of symptoms or with alarming markings like including anemia, he have weight loss and GI bleeding. Prefer diagnostic test because it is highly sensitive for the ulcers and allow for biopsy to rule out malignancy, and rapid urease test for testing H. pylori. Okay, when the patient is more than 50 and the patient has anemia, weight loss and GI bleeding, so you can do upper GI endoscopy. Okay, now lifestyle modification. If the patient is saying I am taking NSAIDs, so discontinue it. Use acetoaminophene for the pain control if possible. Acid suppression for antacids. Stop the smoking. No dietary restrictions unless certain foods are associated with the problems. Alcohol moderation for men. It if he's under 65, to 2 drinks per day, or over 65, and all women can drink 1 drink per day. Stress reduction should be, so if the patient is taking NSAIDs, tell them to not to use alternative can be acetoaminophene for pain control. For acid suppression, antacids. If the smoking is the cause, tell them not to smoke. If there is no dietary restrictions until the something is not food is not related to that, alcohol should be in moderate, and stress reduction. H. pylori testing. If the patient has H. pylori positive, so 3 drugs are very important. Protein pump inhibitor, omeprazole 20 milligram twice in a day. Amoxicillin 1 gram BD. Clarithromycin 50 milligram BD for 14 days. So omeprazole, amoxicillin, and then erythromycin, three drugs. This is a triple therapy we call it.